Good evening, everyone, and thank you all for joining us for tonight's COVID-19 update webinar. My name is Beth, and I am joined tonight by our panel from the RECGP and the New South Wales Ministry of Health. Welcome, Associate Professor Charlotte Hespy, Dr. Penny Burns, Dr. Kerry Chant, and Dr. Kitaki Sharma. So before we get started, I would just like to make an acknowledgement of country. We recognise the traditional custodians of the land and sea on which we live and work. We pay our respects to elders past and present. I'm now going to pass you over to Kerry, who will provide us with the latest COVID-19 update. Thanks, Kerry.
Thanks. And also before commencing, I too would like to acknowledge the traditional custodians of the land on which we're meeting and pay my respects to elders past and present. I think it's probably most useful if I just sort of summarise where we are in New South Wales and then Australia more generally. So we believe we have no community transmission occurring in New South Wales at this time. And we believe that to be the case across the whole of Australia, and hence why New Zealand has indicated that they will welcome New South Wales travellers in the new year without a quarantine period. Now, that status of having no community transmission can change at any time, and I think this is an important point. 10 days ago, we were notified in the evening of a case in a cleaner at a hotel that was servicing quarantined returning travellers. And as soon as you get that case, it draws you to how many more people are yet to be diagnosed, what is the extent. We were very lucky in that case, in the fact that that person was diagnosed quite quickly and did not transmit the disease because of some of the, hopefully some of the protections around the social distancing and other things we have in place. In South Australia, you could see that they had no community transmission, had not had community transmission for a very long time, but their chief health officer one day, was notified of a case, and then a number of cases in the extended family, and then some associated cases. Now, that initial diagnosis was not was in an 81-year-old lady who had presented to hospital with very vague, not serious, nondescript sort of symptoms, but an astute doctor had heard her cough and they tested her. Now, I give you that anecdote because it highlights the importance that 81-year-old was the tip of the iceberg, and when that person was interviewed, it became evident that there were people in her family who had worked in a quarantine facility, and that then uncovered a large number across, 3 households and others in the community that had the infection. If that case had gone undiagnosed, we may have seen generational transmission, a few more generations was spread, and many more people being infected. And then the greater the number of people in the community that are unrecognised, and the longer they remain infectious in that community, and depending on the types of activities they engage in, you can see that cases can transmit it to a large number of individuals. And hence why testing is going to remain important, even though we're in this low zero community transmission. And I know that's probably counterintuitive to many doctors who will obviously advise their patients on what is the pre-test probability of becoming COVID positive. At the moment, it's quite low, but nevertheless, we need those testing rates to remain reasonably high for that assurance that we're not getting unrecognised transmission. We've also got to recognise that our risks now become our borders. So the returning overseas travellers, our ports, people coming into contact with planes and ships that are returning from overseas. So again, we're taking this time to really strengthen our protections. But as you've seen in New Zealand, who's had many incursions, we've had breaches, South Australia, Western Australia. To some extent, whilst we do the best we can to put in all the preventive measures, it's still a reality that these transmissions can occur. and therefore that's why we need community rates of testing to just give us that assurance we're not missing those unrecognised community transmission. We're also strengthening our surveillance, and we've developed a salivary test that we're using in a surveillance context. We're still recommending that the traditional testing is used for diagnosis purposes, but in our quarantine facilities, we are progressively rolling out surveillance testing, again, to give us that early warning, because the earlier we can pick up these cases, it means that our public health action alone can control the spread. We don't need to use any other restrictions on the community. So that's why it's so critical that we maintain those testing numbers, and we're doing all we can to actually prevent any egress into the community. We're obviously also focused very much on vaccine rollout in 2021, and it's been pleasing to see the results, and I'll leave that to Dr. Sharma to describe. We've got a particular focus on developing our adverse event reporting, because we know that having strong community support for the vaccination program is going to be essential, and I'd be very pleased to engage with you on an outline of that program in the upcoming beginning of January, when we've got that more bedded down. We are working closely with the National Centre in relation to that program of work, and we will be strongly involving the college, and Charlotte sits on our vaccine implementation rollout group. So I'll leave it there, Charlotte, and I'm happy to take questions.
Yeah, there's a question just about what testing the quarantine workers are actually having at the moment, and does that align with the Victorian, well, the rest of Australia? Are we all doing the same thing, or is it each state and territory is doing their own sort of testing regime?
So we have been for a while testing health staff in the quarantine hotel, or a health hotel, and they were undergoing weekly swabbing, and that's where our positive cases are moved to that hotel, and also complex patients with complex medical issues. We have now instituted in our police managed hotels salivary testing, and that's done on a daily basis. It's a PCR-based salivary test that's been validated through Health Pathology New South Wales. And basically, that's initially starting with security workers, and then will be progressively rolled out to cleaners and other staff in the quarantine on a risk-based process.
Thanks for that. And then the other clarification is around the testing. I mean, I think there's been a bit of confusion in the GP population, both around COVID testing, the need for self-isolation between the testing result and going back to work, and or what's happening with symptoms. And well, I'll leave that one as the first level of.
So now that we have got no community transmission, we will be looking at the issue about whether we change our guidance in relation to the need to isolate, so that there is no disincentive at all to actually get a test. However, I think that we do really want to continue to reinforce to our patients and the community that going out and about with respiratory symptoms and going into workplaces is probably not ideal, and that with our work from home technology, that it is probably prudent. You can still work from home, but till your symptoms resolve or you get better, it's still probably best not to be in the workplace. So there's probably some things that we've learned during COVID that we probably want to introduce into our main, into our rhetoric going forward.
Couldn't agree more. I think it's good to try and get people to not spread their germs, and we saw that with the really low respiratory tract infections for children, and we're now seeing that sort of popping up with the RSV. But I won't infection rates, which are soaring at the moment. I won't go to that. The other clarification is about wearing masks in practices. I'll clarify, Kerry, that my advice, which aligns with the sort of the RACGP sort of national ones, is that we should still be recognising that we need to keep our practices safe and have those sort of infection guidelines in place. So it's it's the appropriate distancing, and if we are at risk of being with the patient for longer, is to continue using masks. So similar to sort of really what we were doing before, but you know, there is a little bit more flexibility maybe.
Look, and we've taken the same approach in our healthcare facilities, where we're trying to keep our EDs pretty, you know, wearing masks for all patients, just because of the undifferentiated nature of the disease. They're often crowded. There's a lot of interactions with staff. Whereas in other sections of the hospital, it is about that distancing of 1.5. So we've identified emergency departments as high risk, and I think we've seen that through COVID, that the undifferentiated illness coming into that's where you're going to get that impact. And so maintaining focus there whilst relaxing proportionate to the risk in other parts.
And Kerry, the other thing that's coming up here in the questions is around that clearance for COVID testing and the need to basically get a clearance, COVID test to get a clearance test for a child to return to childcare. And I know you've got some comments on that.
Look, I think, again, we will have to reflect and adjust all our advice. I mean, we've just probably had that assurity that we've got to know community transmission in the last few weeks. We had the case in the cleaner at the quarantine hotel, which caused us a bit of redoubling our efforts to be ensured that we had not got any wider transmission in that case. So I think that we will need to just reflect on all of our policy settings and adjust proportionately, but the message still is please test, and it is really almost a community service where we really do want people to be testing to give us that assurance that we're not missing unrecognised transmission. Because if there is a lot of transmission in the community that goes unrecognised for a period of time, and we know with COVID it can, because the symptoms can be so mild, then it is very difficult with public health contact tracing. It can be the best public health contact tracing we've got, but at a certain point, we know that we need to go backwards in terms of some of the restrictions if we did have widespread transmission. Yep. And I suppose that's all. We do also recognise that has consequences, and that's why we all have a part to play in trying to maintain this sort of no community transmission. And we are one of the few countries that, I mean, New Zealand and us, and perhaps some of the, you know, a handful of small other countries might be in the same situation. But to be perfectly frank, we have to accept the uniqueness of the situation we are in Australia.
Yeah, and I think the big reminder is that it's better to be the hero finding that slip through case than being the sort of the practitioner that let it through, and that beside itself is that, you know, one case matters, and so we do need to be able to make sure that we pick it up, and it is harder when there's so few of them, but that's the role we should be playing as the GP, giving good advice.
And I think, Charlotte, if we could also say that, and not that this will work in every case because it may be a few generations past, but particularly if anyone is a border worker, a ports worker, working at hotel quarantine, has family or friends that are working in those high risk settings, to some extent the risk assessment now is very much contact with our international borders is really the risk factors for the disease in the current climate.
I thought we might go over and answer one of the questions here about a brief update on the vaccines, and Kataki's here to help answer those questions.
Sure, thanks for having me. So I'll give everyone an overview of what's happening with vaccine development overall. And the question, I think, was also about which vaccine candidates should we focus on for Australia. So I'll try to focus on those. So at the moment, we've got over 200 vaccines in clinical trials, but 11 are in phase 3. So we're looking to see efficacy results within the next few weeks to months for more candidates. The key vaccine candidates that we're focusing on are obviously the Pfizer vaccine, BNT162b2. That's the one that's now had temporary authorization in the UK and also emergency use authorization in the US with the FDA. And then the Oxford AstraZeneca vaccine, ChAdOx, the Moderna vaccine, which is also, they've made a preliminary announcement of their efficacy and could potentially have some doses available to Australia through the COVAX facility. And then finally, Novavax. And as many of you would have heard or seen in the news, unfortunately, the University of Queensland vaccine has had to be abandoned. The Australian government did have an agreement for supply of that vaccine, but that agreement has been cancelled and further doses of the Oxford vaccine have been purchased. So what we've seen in the last week are phase 3 interim results published for 2 of those candidates. So for the Pfizer vaccine, that was published in the New England Journal of Medicine, and for the AstraZeneca Oxford vaccine that was published in The Lancet. So having a look at the Pfizer vaccine, the overall announcement that they made a couple of weeks ago was that the efficacy was 95%. So excellent efficacy, a really exciting result. And having a look at the interim analysis, there is good efficacy across older age groups as well, and also across people who have stable medical risk factors. So in the trial, you were allowed to participate if you had medical risk factors, including hypertension, diabetes, cancer, obesity, renal disease, liver disease, as long as it was stable and you didn't have a recent exacerbation. One of the key groups that was excluded for chronic medical conditions was autoimmune disease. There was a very small cohort of people with stable HIV who were enrolled, but only 120 or so overall. And so a lot of these groups were too small to provide subgroup analysis in this interim analysis, but we can hope for some more data in their final analysis. And then also, as mentioned, people with obesity. So the study was not powered, but did show good point estimates of efficacy in people who have those medical risk factors. It also showed 52% efficacy after 1 dose. So suggests that if someone comes for their first dose and isn't able to get the second dose, there is at least some protection. But some of the issues for that vaccine, again, a lot of these have been publicised. One of them is the very low temperatures that are needed for the storage and distribution. That's something that could change over time as they do further studies and potentially reformulate the vaccine. That's what we saw with the Moderna vaccine, that initially had to be stored at -80, but then they revised that to -20. So that's something that potentially hopefully could happen. It would make distribution much easier. It is a multi-dose vaccine with no preservative in the vial. So that has implications for handling and administration, which need to be taken into account when developing training for immunisation providers for this vaccine. And also it requires reconstitution, and the dose quantity is 0.3 mils, which is not a standard dose. It's also different from the dose of the Oxford vaccine, which is 0.5 mils. So that's something that we need to providers really, we want everyone to be aware of, that it's an unusual dose that we're not used to, and a 21-day interval as well. Then the other thing that's been in the news about this vaccine is the 2 allergic reactions, and there's a 3rd possible allergic reaction that was reported in the UK. We don't have a lot of detail clinically about exactly what happened, but we have read that these 2 patients had a history of anaphylaxis and carried EpiPens. And the UK Medicines Authority has issued guidance that anyone with anaphylaxis to anything, so to a food or another medication, should not be given this vaccine. The FDA has taken a different approach and said that it is contraindicated in only those with anaphylaxis to a vaccine ingredient. And so obviously we will have to assess that in Australia as well. Looking at the ingredients, there aren't any common allergens that stand out in this particular vaccine. It doesn't contain gelatin, it doesn't contain egg protein. It does have polyethylene glycol, so that's something that will need to be assessed as to whether that's a possible allergen. But I think it's likely that Australia would follow the approach that, at least in people who have had an anaphylaxis episode to any of the ingredients in the vaccine or to a previous dose, that they shouldn't be given the second dose, and that the vaccine should only be administered in a setting by a provider who's trained in recognising anaphylaxis. And as you would all know, this applies to all vaccines that we deliver anyway. And then the other vaccine that had phase 3 results released. And so this is one where, again, widely publicised, the very unusual, some of the ways that the things that happened in the trials were a little bit unusual. So one of the issues was that there was a significant cohort who received a different dose regimen, which turns out to have been due to a manufacturing issue. So they received a low dose for their first dose and then a full dose for their second dose. And they actually had better efficacy of 90% compared to the cohort that had a standard dose and a standard dose. A couple of theories for why that could be. One could be that there might have been underlying differences in the actual cohort vaccinated, such as the age group. Maybe it was a younger age group that got the low dose standard dose. But the other possibility is that having a low dose might have triggered less antibodies against the vector, the adenovirus vector, and maybe that actually led to a better boosting response with the second dose. So this is something that now needs to be assessed in subsequent trials. So we can't say at present what the best dosing regimen is for this vaccine. The other issue is that they had recommended a 4-week interval, but looking at the actual trial, a significant proportion of the participants actually had a much longer dose interval of 6 weeks or more. So it is possible that that may have also contributed towards the efficacy, and perhaps the dose interval also needs to be assessed. So there's sort of a lot less certainty about how this vaccine should be used, how effective it is, but it will hopefully that, there are multiple phase 3 trials ongoing. Hopefully this information will come out. Some of the other issues with this vaccine are, again, it's a multi-dose vial with no preservative, and efficacy at the moment wasn't demonstrated to be as good for older adults, but there are no safety concerns theoretically for its use in people who are immunocompromised, and both of these vaccines were safe and well tolerated by the vast majority of participants. That severe adverse events were extremely rare. They did tend to cause local reactions and systemic symptoms that we would often see after vaccination, like fever and tiredness. The other issue, the one that we don't know, is being new platforms, we can't comment on the duration of protection that we're likely to achieve with either of these vaccines. So that's something that we need to watch over time. So I've talked a lot. I'm very sorry. I could keep talking. There are a few other vaccines that have been licensed for sort of restricted use in other countries. And so we're going to get hopefully post-marketing data on those. But I think I'll just stop and have perhaps let you guys ask questions.
Thanks so much, Kitaki. Just a clarification on what does 95% efficacy actually mean? So is it, just so we have a better
I can see that question. Yeah. So the antibodies developed, that part is assessed in phase 2 studies, and we call that immunogenicity. So just the ability to trigger an immune response. And so all the phase 2 studies were measuring neutralizing antibodies, anti-spike protein antibodies, and then reported what percentage had developed antibodies. That doesn't actually tell us if it protects you from getting the disease. So efficacy is a term used in phase 3 trials, which tells you whether you're in the group that was vaccinated compared to the group that was receiving placebo, how effective was the vaccine in preventing disease. And then the definitions of disease are very important. So both of the Pfizer and the Oxford vaccine trials only were able to report on symptomatic disease. So there was a subgroup in the Oxford trial that they swabbed them every week, but we don't yet know how effective these vaccines were at preventing completely asymptomatic disease. And so that's immunogenicity is phase 2, looking at the ability to produce antibodies. Efficacy is phase 3, looking at the ability to prevent disease, whether that's disease at all. And so if you were swabbing people every week and working out the rates of asymptomatic disease, that would also help you work out how effective it was in preventing transmission. And then after a vaccine is actually licensed and used in a population, we then refer to that as effectiveness, because obviously clinical trials, you have healthy young participants, you have perfect adherence to the recommended doses, and in the real world, the actual effectiveness is often worse than what we see in those phase 3 trials. So that's sort of the terminology we use.
Fantastic. Thanks, Kataki. There's another question here about administering it with the flu vaccine and how that would work.
Yeah, that's an excellent question. So Novavax is the only vaccine candidate where they are intentionally doing a flu co-administration study. So we will hopefully then see some immunogenicity data for that particular vaccine. It will be too small to get efficacy data with the co-administration. The other clinical trials, so Oxford, they allowed participants to have the flu vaccine, but they haven't recorded whether or not they actually captured that. So we won't know the impact of co-administration on the immunogenicity of either vaccine. And then the BNT, so the Pfizer vaccine, they weren't allowed to have the flu vaccine within 14 days either side of having their study vaccine. And so in the first instance, we will have to make a recommendation based on expert opinion because there won't be actual data on whether there's interference caused by the immune response to one of these. People are recommended not to have the two vaccines on the same day, and perhaps the conservative approach would be leave a 14-day window. So it's going to be tricky because the campaigns are going to come out at possibly the same time. So in March, we could have a COVID vaccine and we need to vaccinate healthcare workers against flu. It might be that people are asked to get their flu vaccine first, then 2 weeks later start their COVID vaccine, or the other way around. But as always, there may also be a risk-benefit assessment that's involved. So if it's logistically, you know that this patient is not going to come back again and this is your chance to give them both, I don't think theoretically there are any safety issues anticipated with giving both vaccines, just we're not able to guarantee the efficacy. But all of this is being studied and there will be some formal guidance from ATAGI on whether or not and the timing of the two vaccines in relation to each other.
Thanks. And a clarification, none of these vaccines are live. They're all using bits of the virus as the coding for the vaccination. There was just a question to clarify that.
Yeah, it's a tricky question because the viral vector vaccine, so Oxford is one of them, but there are quite a few others in development. The virus itself is technically live in the sense that it is still the goal of that viral vector is to take the mRNA piece into your cells, but it then can't replicate. So we don't consider it to be along the same lines as a live attenuated vaccine. And in particular, in terms of safety in immunocompromised people, it's not anticipated that it would be contraindicated in the same way as a live attenuated vaccine. But then on the other hand, as everyone would know, when you are giving live vaccines, we usually recommend a 4-week interval between two live vaccines. That's partly because of your immune response. I don't know whether the immune response to this viral vector would have a similar interference potentially, and whether the timing might need to be different. That's something that will be worked out down the track. But yeah, it's not a live attenuated vaccine in that sense.
And Kataki, does that mean that, what does that mean for people that, there's a couple of questions here, that have had COVID and those that who have recovered from or are recovering from COVID?
So again, pretty much every phase 3 trial that I have looked at, the inclusion and exclusion criteria for has excluded people who have a past history of COVID. So I think, and perhaps others will be able to comment, that now that we know you can check the nucleocapsid antibody, that's a possible antibody that can help people to actually have the infection. So it might be possible to then test and see if the vaccine was given to people who were infected. But to my knowledge, there isn't any data on the vaccine efficacy or safety in people who have had COVID. And that's something that certainly needs to be looked at.
There's also an interesting question, and I'm not sure on the slant, but the wording is it's about people going back to China, wanting to have a flu vaccination, but worried about a COVID serology test showing a false positive. Do you know anything about that, and what is the risk for that for those travellers?
No, I haven't come across anything that would suggest it would trigger a false positive. I would certainly recommend that they should have the flu vaccine. Don't know if anyone else
So
has
I think the issue is more about it having a reaction, or not getting as much of an immune response. Though interestingly, it's a bit like the pediatric ones. We see that you get a better response if you give everything all at the same. I mean, well, there's no decreased response by giving everything all at once. So let's hope down the track we can do it as a dual vaccine, because you definitely will increase the compliance and adherence to getting it done.
Absolutely, and so many of these things, I think over time, you would hope that it will turn out to be just like other vaccines, and you'd be able to give it at any time in relation to other vaccines and co-administer. It's just in the absence of any data, usually the initial advice may be more conservative.
Taki, can I ask you how, I know there's not any evidence yet, but the likelihood of the length of protection that this vaccine might give us, is there any indication as to how long that might be, or will it need to be an annual one?
So it's really impossible to predict. However, what I can say is that if we're looking at the platforms, we see the best duration from live attenuated vaccines, and there are, I think, only 4 even being looked at for COVID, and none in phase 3. So that's not really something that's on the horizon at the moment. But the live attenuated vaccines and whole inactivated vaccines have the benefit of having, or we know that they tend to produce quite durable immune responses, whereas subunit vaccines, and that would include, for example, the Novavax vaccine, and these protein-based vaccines, so the mRNA and live viral vectors, are really only exposing your immune system to that spike protein. So theoretically, they may not provide as long protection as a live attenuated vaccine, but being such new platforms, I actually asked this question of my own boss because I wanted to know, and they didn't have a good estimate either, so I don't know, sorry.
I'm also curious, can you tell us a little bit about the approvals process in Australia? So given that we really aren't in an urgent situation like the UK and the US are, in terms of needing to contain spread of infection and cases, etc., urgently, because it's so dire there, and we have the luxury of being able to sit and watch and see the safety and rollout type data. What do you see as being the timeline in terms of what are we likely to do from a TGA perspective in terms of approvals, and when is it realistic to be then seeing the sort of the rollout into the community?
So the way the process works, and each country has had their own version, is sometimes referred to as a rolling review. So they can issue a temporary authorization based on available data to date, and the TGA has very stringent standards which will still be in place for any COVID vaccine. But the rolling review means that they will expect the developer to continue to provide them with further data as it comes out, and then the recommendations can change. And so theoretically, the vaccine could be pulled from the market if a major safety issue is discovered, or there could be changes, as we saw in the UK, to the recommendations for the groups that it is offered to. So the TGA will have a similar provisional approval process. And only when they feel on safety and efficacy would it be fully authorised. So that's how the process sort of works. I think the timeline in Australia, as you point out, we have we're in a very fortunate situation that we don't have the same extent of urgency. And I think what that will mean is that we will be able to really focus on triaging the priority groups very carefully, and it may have to be the case because we are likely to only have a limited supply, and the estimates in terms of timeframes would, I think, be first quarter of 2021 is what I'm hearing as the most likely timeframe. But as we know, we're not going to have any data on children for a very long time, and fortunately they're also sort of low priority. And so similarly, it would really be, I think, looking at the older age groups, looking at frontline healthcare workers, essential services workers, where you might think the risk-benefit ratio for them is strong enough that you would want to vaccinate them even with a provisionally approved vaccine, and the rest of the population will have to wait and also will be at lower risk. So I think by the end of 2021, we may then start to see a broader program, but obviously these are guesses.
And there's another question here that about how soon is antibody formed after vaccination. And I know there's a beautiful graph that we could probably send around from the Pfizer vax that shows after 10 days shows quite an effect. Is that the same for all of the vaccines?
Yeah, so I don't know that off the top of my head for the Oxford vaccine, and if anyone does, please chime in. But in general, we expect to see a partial response 2 weeks after vaccination. And I know in the Pfizer vaccine, they did see that 10 days after dose 2, there was quite a dramatic split in terms of the vaccinated and unvaccinated groups. And by 4 weeks, we'd expect to see a peak antibody response. So we usually tell people that if you're, if it's for overseas travel or for a particular risk, we usually recommend 4 weeks as the interval to assume that you've mounted an adequate response.
But that's after the second vaccination. So to
after
be clear,
the second dose,
you do need
yes,
the second vaccination dose to trigger that response.
Absolutely, because the efficacy after the first dose for the Pfizer vaccine was only 52%. And then 95% after dose 2, which really shows you that the first dose, and especially for the viral vector vaccines as well, is intended to prime the immune system. That's not your full vaccination.
Kataki, are you able to expand a little bit more on the side effects? I've seen some lists there of very high percentages of adverse effects after some of the vaccinations, with, a third of people getting high temperatures afterwards for a couple of days. So even younger people getting quite high percent, I guess, of adverse reactions. And I know, working in a respiratory clinic and seeing the adverse reactions that people have to swabbing, I'm just a bit concerned they might have the first one and then really not want to have the second one.
Well, so maybe this is a positive. The systemic adverse events for the Pfizer vaccine really seemed to be worse after the second dose, and over 50% had systemic adverse events. So things like fever, fatigue and headache, they were the most common, but they were actually less common in the older age groups, and those systemic adverse events were less common after dose 1. But local adverse events were certainly common after both doses, and it was about the same. And so that would include things like, significant arm swelling and injection site pain. And so that could certainly be a deterrent. But I think for both vaccines, the Oxford vaccine, they actually gave prophylactic paracetamol for some participants. So for both vaccines, paracetamol won't be contraindicated. We wouldn't recommend it prophylactically, but I think we could definitely counsel patients to expect some local symptoms and certainly to expect the possibility of systemic symptoms and take Panadol. But yeah, hopefully we don't see so many systemic reactions after the first dose to stop people coming back for their second dose.
So what numbers are we looking at? So what percentage would we be expecting it to happen for?
I don't have those numbers off the top of my head, I'm sorry. So I know that mild and moderate adverse events were very common for the Pfizer vaccine, I think for both vaccines in particular. Severe adverse events were very rare, but I don't have the numbers of specific adverse events, I'm sorry.
That's okay. At this point, I might also sort of take us a little sideways because we don't have any other new questions coming in. Just going back to the Queensland vaccine, do you want to take us through what the scenario is as to why it was cancelled? Because it does look like it was actually quite a nice vaccine with a good efficacy.
Yeah, it did look like it was immunogenic, so it produced a good antibody response, and it was safe and it was well tolerated. The issue was that the vaccine was focused on the spike protein of the coronavirus, but the spike protein is quite unstable. It has a pre-fusion format before it actually fuses with the cell membrane, and then it has a significant conformational change. And then the problem is, if you just vaccinated with the spike protein by itself, your immune system would be recognizing potentially that post conformational change. And so what they did was they used a protein, just a fragment, which was just 80 amino acids, a protein fragment from the HIV virus that was very effective in clamping the spike protein into that pre-fusion format. And that means your immune system would be recognizing the spike protein in the same way it looks when it's on the surface of the actual coronavirus. So that was why it was included. They knew that there was a possibility that you could develop antibodies to that fragment from the HIV virus, but the researchers thought that that was a low possibility, but participants were counselled about that. And unfortunately, it turns out that they did develop an immune response to that fragment of HIV protein, and that was able to create false positive results on HIV screening tests. So you could potentially get around that by doing either further tests to rule out that this person doesn't have HIV, but obviously it would cause a lot of unnecessary anxiety and confusion. And so that was something that really just wasn't able to be circumvented. So that was the reason they had to stop the vaccine. But otherwise, it was certainly a promising platform that can hopefully be re-engineered and still progressed.
I wonder if we could.
Does that antibody potential?
Oh, sorry, keep going.
Oh, I was just going to say, somebody said, does that antibody potentially protect people from HIV? So I think, so kind of like we were talking about before, just because you generate an antibody, it doesn't actually mean it's going to be protective. So hopefully they look into further uses for this particular clamp. But my understanding is that no, this HIV, just because you generate antibodies to something, unfortunately, doesn't always mean that they're protective.
Thanks, Kataki. I was actually going to invite Kerry back in. She's still there. Just wondering, with all this vaccination going in, I just want to ask her about how long she sees the testing going on for, given that we're rolling out vaccinations. So how far into 2021, or what effect it's going to have on the continuing testing?
So I think that we're all very pleased with the vaccines that have come online and the effectiveness, the efficacy data that's been released to date. I think, though, we need to make sure that we're hearing what Dr. Sharma's indicated, in that we are not going to be able to fully vaccinate the population in the first half of 2021. And that's due to probably the most critical element is going to be the physical constraints of having the sufficient vaccine available to us at that time. That means that we are going to have to navigate COVID throughout 2021, and we're going to need to maintain those testing. Now the environment is going to change throughout 2021, depending on how quickly countries overseas vaccinate their residents, what other strategies we put in place in terms of vaccinating travellers. So 2021 is going to be a year where we're going to have to adjust and respond to what the COVID environment and context is. It may be that we move from a setting of no community transmission to having a low community transmission environment, but heavily mitigated with vaccination in terms of travellers coming to this country. And so I suppose it's going to be a journey which is unpredictable at this point in time, but we're going to have to clearly work in partnership with GPs as we nuance the messages. I've also reflected that our public health response will have to change during 2021. You know, at the moment, we are aggressively tackling any case of ring fencing it, doing upstream testing, tracking down casual contacts. Throughout 2021, as we progressively vaccinate the population, again, we'll need to moderate our public health response to be proportionate to the risks, as we've got vaccine in the toolkit to mitigate COVID. So 2021 is actually going to be just as challenging as 2020. And I say that with some foreboding, but we will be having the access to a vaccine, as will most of the world. So that is a pleasing place to be, and one that we probably didn't predict when we started the COVID pandemic. So we're very blessed that we have got such effective vaccines, potentially effective vaccines on the horizon.
Thanks, Kerry. That's actually, it's good and bad. It makes me feel very tired to hear that. Look, I think you're also, when we were chatting earlier, mentioning, talking about using other ways of surveillance to sort of take the pressure, I guess, a little bit off swabbing. I can see some of the questions in there reflect what I feel on a day-to-day basis when I'm faced with very stressed, anxious young parents who are really cross and angry about having to get their child tested again for the 5th time. And many of them actually, I had 3 refusals today, and adamant parents saying they don't have COVID, they've just got a runny nose, or they've just got a COVID, a childcare cough. What are the other options for us around testing besides just the respiratory PCR?
So I think that as we progress, we'll have to figure out how salivary PCR testing can fit in the mix. It's not quite as accurate, but it may be sufficient if we want to put that in the mix. Clearly, we're using the sewage surveillance also as a way of assuring ourselves that we're not missing undiagnosed transmission in the community. It works best in rural environments where we're not having a lot of returned overseas travellers. People can excrete the virus for many weeks, and so that does present challenges when we have people arriving from overseas, many of whom have been infected overseas, who will then make interpretation of the sewage results challenging. But we will need to have a culture of testing, as I said, perhaps reframing our messages to the priority areas for GPs, and perhaps tailoring it to when we actually have sewage results positive, again using some of those indicators to really drive community testing behaviours.
I guess one of the other questions that has come up has been around distribution of flu vax as well. And I know that that's a really difficult question. We had a question come in earlier wondering how that would happen from a very practical point of view due to some of the issues we had last year with getting access to timely vaccinations. And I don't know that you can necessarily answer this, Kerry.
Well, certainly we've ordered a lot of flu vaccination, and I think partly last year was the highest amount of vaccine that we ever got out in terms of the demand. So I think that probably was unpredictable. We'd had a good year the year before, but it was even more significant demand in 2020. I think we've learned lots about distribution, and I think we're really wanting to work with GPs again about the estimates. We know that there was still maldistribution, so vaccines left in some GPs' fridges and some GPs were running out. So it is it is not a perfect science, because your patients will seek vaccines from, different GPs or move around, and so I think we have to accept that we will do our best. We continue to learn after every flu season how we can do it better. And we have got that distribution and the historical understanding of what people used last year. And I think, that's probably something we need to work with you early. But I'm confident we will, get the flu distribution system out. And the Commonwealth is separately distributing the COVID. And as I said, whilst there is some chance that there'll be an overlap, I think the prioritisation there still will be scarcer supplies of the COVID vaccine, and so a much more prioritised group will be vaccinating concurrently with flu vaccine.
Can I also chime in at that point, Kerry, and say that I know we have been doing a lot of work on the distribution of it, and so the current plan is not so much to be using the swappy formula, which I know has been suggested at some levels to use our swappy number, which is the number that gets calculated at a national level about how many patients are coming to a practice regularly, but instead to actually align it with every provider in the practice's uploads of the immunisation register numbers. So actually to try and get a much better understanding of exactly the numbers each practice gives, because we know that swappy numbers don't actually necessarily align with the number of flu vaccinations. And so it does actually help bring out those practices that have got a whole lot more elderly patients and or patients that do need flu vaccination versus for instance, you know, a practice that really has more people in a middle sort of generational or younger who are much lower risk and not needing to have so many flu vaxes. So I actually think that's a really nice alignment, but it does mean that that all practice managers are being asked to make sure that they give the numbers of their providers to New South Wales Health, so that those formula, you know, those sort of numbers can be calculated about, you know, what providers you did have. So it's a bit complex if you had doctors who've moved on, but you need to provide that information to make it so that it is much easier to get the right numbers for your practice. And then there does need to be each practice needing to take a responsibility about how many they do realistically give and how large a fridge they can access. And one thing I know this year was practices just ordered a small amount rather than actually ordering the amount they thought that they needed. So then there was a misalignment between some practices getting far too few versus others getting far more than they needed. So recommend getting a bigger fridge if you think, when I say bigger fridge, what my practice did was we actually rented in an extra vaccine fridge so that we could actually just fill it up with flu vaccines for that acute time point, which was fantastic. It really did mean that we had enough on board to vaccinate as we needed to.
And Charlotte, I think that's a really good idea, in that we're going to need to also it'll be mandatory to upload COVID vaccines to AIR. So getting into that, the swing of really using AIR a lot more is going to be really important. And then there's a couple of questions that have come up related to that is, you know, should we be recalling patients for flu vaccines separately to COVID? And that, of course, Kerry, I'll let you answer that.
Sorry, my screen's gone blank at the moment. So sorry, I'm back again. So I think that we should be, depending on the knowledge we have at the certain time. So I think until we get that Hatahagi advice around concurrent administration of the COVID and what the distribution path is at that time, we will certainly be trying to get the flu vaccine out in a timely way and get people vaccinated to try and minimise any impact of having COVID vaccine requirements at the same time. But I think we will be waiting also for that evidence about whether concurrent administration poses no risk, because we know that again, that is better for our patients if we can vaccinate them at the same time and it doesn't impair their immune response.
And then I guess the other question that's
coming... Can I just add something on that? Sorry, I just wanted to add that one of the other possible concerns is just public confidence. And if we give them both vaccines on the same day, actually lead to slightly worse adverse events, having had two vaccines, and make it potentially a little bit harder to work out which vaccine to attribute those side effects to. So in this early stage, that's another consideration. But yeah, as being out.
And Dr. Sharma, there's a couple of other questions here that are coming up which are really relevant to you, which I think are really important. Is the questions about, do we know what the criteria will be for COVID vaccination in order to, so GPs can recall the right groups, and will the doses be different for different age groups?
So on that first question, so one thing that ATAGI is looking at is very detailed data on the actual odds ratio of having severe COVID for different risk factors. And so the prioritization, where they're creating a matrix that is really quite detailed, and the goal is to produce a matrix that will tell you for the first, the highest priority population, which is this risk group, the next to 500,000 doses can go to this group. And so that takes into account that, there may be delays and the timing is quite difficult to predict, but at least the prioritization will be set out. So we don't know that yet because the epidemiology is still being assessed to determine who is the highest priority. The other thing that will be taken into account is the vaccine characteristic. So all priority groups, and as I mentioned, there's currently no clinical trial data for children. So even children with, say, chronic conditions are not going to be able to access the vaccine, as it won't be initially licensed for children. Similarly, adults with immunosuppression, even though there may not be any theoretical concerns, they were routinely excluded from phase 3 trials. So although they might be high priority, they may not be able to access the vaccination. And then the other thing to take into account is the logistics, that the Pfizer vaccine in particular is difficult to transport. And so therefore, if it was to be transported to a remote community, you might then not be that strict and say only the above 75s will get it. You might think, let's just give it to all adults because we've had to go all the way out to this community. So all of those sort of factors will be taken into account in creating this prioritization matrix. And then as for the other question about doses, as of now, what we know from the phase 3 trials are the standard doses for adults. So for the Pfizer vaccine, that will be the 0.3 mils. For the Oxford vaccine, they haven't actually optimized what the dose regimen will be because there was that difference in efficacy between the two different dosing groups. And there's another possibility as well, that sometimes with these adenovirus vector vaccines, to get around the fact that you develop antibodies to the virus, the vector virus, it might even be combined with a different vaccine. So there's a trial about to start where it will be combined with the Russian viral vector vaccine. So a lot of that is yet to be determined as to what is the optimal dose. And then the dose potentially could be different down the track for children or for older adults, but none of that has been evaluated yet.
Thank you.
So it truly is a watch this space scenario, really. And, and that does mean I think we're in that very fortunate position of being where we can happily take it a little bit slower than everywhere else, given that there's so much change. And hopefully we'll end up with the easiest vaccine. I mean, when I sort of heard it's multi-dose, 5 in a vial, needs normal saline as a diluent, it's got to be cloudy. Well, it's got to be white in order to be okay to then draw it up, and it's 0.3 of a mil per vaccine. I thought, oh wow, this is going to be, one of those vaccines that you really do need to be thinking and doing as a separate clinic, really, rather than just doing it as part of business. So that I think needs all of the practices to really be thinking out how we do it and make sure everybody, well, I think from my understanding is everyone is going to have to be specifically trained in order to do this prior to doing it. So it's not one that just because you're a GP, you'll be able to do it. You'll still have to do the special education.
Yeah, there are so many differences from what we're used to, because not only is it multi-dose vial, but there's no preservative, which means aseptic technique is really important. So there will be detailed training taking place.
There are some nurses around that have remembered the H1N1 pandemic and using the multi-dose vials then, and we actually found an old college advice on how to roll that out. So I think there'll be lots of advice coming out on how to do these things. And then there's a question that's come here. Due to storage issues, can COVID-19 vaccine be given by a GP or in a special clinic?
So I think initially, partly because of the storage issues, the fact that it's a multi-dose vial, and the fact that there will be limited supply, it may be the case that it is delivered in targeted clinics, and then eventually, part of the reason it's in a multi-dose vial is also just global supply issues with the actual equipment, the actual glass vials. So down the track, in an ideal world, we would have single-dose pre-filled syringes, and you would be able to deliver it in a opportunistic setting. But initially, I think it possibly makes more sense that it's in a targeted, focused immunisation where you know that you're not opening a new vial for the one patient who turns up at 5 p.m. and then you have to throw out the rest of the doses when we know there's only limited supply and there's only a 6-hour window to use up the entire contents of the vial. So for many of those reasons, and the fact that once it's defrosted, it has to be used up within a number of days, it really will need to be planned to minimise wastage, as well as making it, a rated program.
And I'm afraid we've run out of time. And so thank you very much. I'm going to hand over to Bethany to round this up.
Thanks, Penny. So yeah, unfortunately, this is all the time that we have this evening, but I just wanted to say a big thank you to our panel. So thank you, Charlotte, Penny, Kataki, and Kerry for this informative session. And thank you to everyone online. I hope you enjoy the holidays. Have a great evening.
Thank you. And here's to an interesting 2021 for all of us.
Couldn't have said it
and
better.
hope everyone has a break over Christmas.
Thank you.
Thanks. Thank you. Thanks, Beth.